Kopp, fourth-year resident, will talk about ventral hernia repair, open ventral hernia repair. Thank you.
Welcome to this morning's talk on incisional hernias. It's a broad topic, and for that reason I'll be focusing on the open management of these entities. So why are incisional hernias important? Why bother talking about them? Firstly, we need to know what we're talking about. I'm sure we all know our definition of what a hernia is, but just to refresh, it is a protrusion of a viscous or preperitoneal fat through the abdominal wall. That is an abdominal hernia. In terms of classification, there are multiple classifications. However, that of the European Hernia Society is most oftenly used, particularly with regards to publications. And it's also useful to distinguish the entity of incisional hernia versus a burst abdomen. Any of my colleagues in the back have an idea of how we can distinguish that? What is the most important distinguishing factor?
The burst abdomen is more in the acute setting and incisional is chronic over time.
Absolutely right, thank you. So that's the right way to think about it. It's pretty much just time separating these two entities. So burst abdomen can be thought of as acute wound failure. It's got an incidence of about 2%, relatively high associated mortality of about a quarter of cases. It is often preempted by the presence of serosanguinous fluid, and it's important to recognize in these cases that the peritoneum is open. In comparison, incisional hernia is chronic wound failure. It has a very high incidence. After laparotomy, up to half of laparotomy cases are affected by incisional hernias. Most of these, over half, occur only 5 years after the index surgery, and over half of these are also asymptomatic, and important to recognize that the peritoneum is intact. So why bother talking about this? Well, incisional hernias still complicate, as mentioned, up to half of all laparotomies. It remains the most common complication following laparotomy, and it's the most common indication for reoperation exceeding bowel obstruction by 3 to 1. And finally, as we all know, the best method and location for implantation of mesh is still hotly contested. There's an increasing incidence of incisional hernias, and just to distinguish, incisional or any hernia can be complicated either by incarceration, just like when you go to jail you can't get back out, or strangulation when the blood flow to the hernia contents, often bowel, is threatened, and that's a surgical emergency. How can we prevent incisional hernias if they affect us so much in surgery? Colleagues in the back, so we can look at modifiable risk factors, things that we can do as surgeons, things that we can try and alter in our patients. Any ideas what we can try and alter in our patients?
Smoking.
Absolutely. So pretty much all of this is related to impaired wound healing. Very active colleague in the back. So he drunk his coffee. So all the risk factors in bold are modifiable risk factors, and they all have to do with impaired wound healing. So reduced tissue perfusion affected by diabetes, smoking, age, reduced collagen synthesis, vitamin C deficiency or genetic deficiencies, Marfan's, Ehlers-Danlos, increased intra-abdominal pressure, obesity, ileus, respiratory problems, and very important for our patient cohort here in USED obviously is immunosuppression, transplant patients under steroids, chemotherapy, radiotherapy, etc. And this can all be summarized under the triad of intra-abdominal pressure being raised over time compared to abdominal wall weakness. That's a good way to think about it. And what can we do as surgeons to reduce the incidence of incisional hernias? This is now pretty standard. The publication reference here is already published in 2009. I've only seen this being done, or this is the only way we do it here as far as I've seen. Continuous closure technique, monofilament, slow resorbable suture material, suture length to wound ratio of at least 4:1, but no greater than 5:1, small steps and small bites between 0.5 centimeter from the fascial edge and 0.5 centimeter between bites. And one of the interesting areas in the management of incisional hernias is the opportunity to start placing prophylactic meshes after elective laparotomy cases. And our very own consultant, Dr. Brosey, published this year in the World Journal of Surgery a randomized control trial of about 270 patients undergoing elective laparotomy, randomized to not receiving a mesh, just normal classic continuous closure versus receiving a prophylactic mesh. And the results are pretty significant. So you can see there's a significant reduction, almost 50% less occurrence of incisional hernias with patients receiving a prophylactic mesh compared to those not. And what's also important to recognize here is that the rate of incisional hernia is pretty high, 40% for people not even receiving not receiving a prophylactic mesh. So when do we operate? When should one operate? Well, first we've got to diagnose the problem. This is pretty well known. MRI is the gold standard when it can be afforded, when it's available. Otherwise, CT is also very good, very high sensitivity with or without Valsalva. Important to recognize that, unfortunately, clinical examination alone or with ultrasound misses about 30% of cases. The most frequent indication for operating incisional hernias is when they become symptomatic, causing pain, when they're incarcerated or obstructed. Only about 6 to 15% of operations are emergency operations in obstruction. And it's important to recognize or remember that the risk of strangulation goes up in hernias between 2 and 4 centimeters of size. So very small hernias probably, well, they're not big enough to let bowel through, and very large hernias are very easily reducible. So this size is important to keep an eye on. And what to do with asymptomatic hernias is still not really known. It's undergoing a lot of debate at the moment, and there's a big multi-center trial called the AWARE study that's aiming to address this issue. Finally, how to operate? Well, we put a mesh in. That is standard, that's gold standard. That's not debated anymore, but where to put it is still debated. We've got plenty of options, pretty much covering all the fascial layers of the abdominal wall. Onlay, put it on top, bridging between the rectus abdomini, sublay, underneath the rectus abdomini, preperitoneal or underlay, and then intraperitoneal. And it's important to do a good reconstruction or good treatment of an incisional hernia is really to recognize and know the anatomy. And there's 3 important points to highlight. So at the level above the costal margin, the rectus abdominis is sitting on top of the costal cartilage. So putting a sublay mesh underneath there is not really appropriate because it's going to be riding on top of the cartilage. Above the arcuate line and below the arcuate line, the fascial sheaths arrange themselves differently. It is important to recognize above this line that the linea semilunaris will limit you laterally placing any sublay mesh underneath the rectus abdominis muscle. And finally, we can see here that the anterior and posterior rectal sheaths are invested by fascia from the internal oblique muscle, and this changes underneath the arcuate line where the anterior rectal sheath is invested by all the lateral wall muscle fascia layers, and the posterior rectus sheath is comprised of the transversalis fascia. So in essence, when one inserts a sublay mesh under the rectus abdominis here, it's pretty much the same as an underlay mesh or a preperitoneal mesh. So that's great, but which one should we use? So we cannot really say, but we can make some rough conclusions based on what literature is available. So firstly, regarding onlay, it's still used, but it's got still a higher recurrence rate than other techniques. And one of the main issues associated with this placement is it is associated with higher rates of infection and seroma formation. Inlay is virtually not used at all anymore. It's got a very high recurrence rate. It's not really recommended, but it does still have a role in the management of complex open abdomen treatment. And it's easy to understand why. When you put a mesh here, there's not much overlap, and the physics of raised intra-abdominal pressure are just going to push that mesh right out. Sublay and tar is really one of the gold standard methods at the moment. This was really developed by Reeve and Stope in 1965, has evolved tremendously since then, has a lower recurrence rate. The classical Reeve-Stoper method is limited at the linea semilunaris, and that's why further evolutions of component separation, such as transversus abdominis release, which allows mesh to come further lateral, have more of an overlap, able to address larger hernias, more complicated hernias, and has been shown to have one of the best recurrence rates or lowest recurrence rates. But again, you are limited anterior to the ribs. And preperitoneal, this is favored in our hospital because it's very versatile. It can be used to manage many different hernias in different sites and also sizes. It also has a good recurrence rate or low recurrence rate. There's no limitation by the linea semilunaris, and it also preserves the vasculature and the nerves which are situated underneath the rectus abdominis, and that could be seen as one of the main advantages. And finally, intraperitoneal is really known or seen most often with laparoscopic approaches, but it also can be used in open incisional hernia repair. The risk here is that the mesh is coming into direct contact with bowel, and the risk of, therefore, risk of adhesions and erosions is present. So I won't go into too much detail on this because there are a lot of different methods for component separation. Again, developing on the Reeve-Stoper method of sublay repair, allowing you to get more lateral by either going through the transversus abdominis, for instance, in tar. As you can see here, there's many different methodologies. But even in large hernias, it's not often necessary. In our hospital, we have a lot of experience managing incisional hernias as a referral center. And in many cases, this can be managed with the application of a underlay or preperitoneal mesh, and the abdomen can be successfully closed. What does the future have in store with us? Well, all this fancy surgery might be not needed anymore in a few years with the application of Botox in the lateral abdominal muscles, which allows the rectus abdomini to move further back into the midline, restore normal anatomy, and be then reconstructed with a classic sublay technique, for instance, not requiring any of the complicated component separation. Finally, quality control experience is very important. This paper showed clearly that anyone operating less than 35 cases a year doesn't have as good outcomes, frankly. There's a significant reduction in recurrence rate, cost, and time for surgeons who are operating more than 35 cases a year. And that might not seem like much, but if you think about it, it's almost one a week. So that is very challenging for smaller hospitals who might be operating, but not necessarily having the experience to deliver good quality. So what are the take-home messages? It's important. It might not be fancy, but it's very important. It affects half of our laparotomy patients, up to half. How can we prevent it? With proper surgical technique, proper closure, and hopefully, and the evidence does suggest we should be applying prophylactic measures to elective laparotomy patients at least. Diagnostics, CT, MRI. Indication, at the moment, it's symptomatic hernias, common sense. Also, patients with pain, but with very high risk factors might not be suitable to be operated. Technique, as mentioned, it's the sublay technique with or without component separation, or the preperitoneal technique that at the moment is the gold standard and has the lowest rate of recurrence. As mentioned, for very giant hernia, large hernias, component separation might be required. How do you deliver quality with experience? More than 35 cases a year. Thank you.
A very, very good presentation. Thank you very much. I think that will add to our curriculum here for surgery. I also enjoy your accent from the UK, I may imagine, no? South, North, London. Okay, right, that's very good.
First English presentation in a year and a half of doing bad German presentations.
Okay. We may not want to know everything, but this one was extremely good. So thank you so much for this. Two questions. Maybe it goes to Dr. Kaiser. I mean, a bit to discuss. I mean, for me, I think this is clear, as you have shown here, that mesh are needed, right? I mean, here, that's probably very wrong. I was still less convinced for inguinal hernia, where we have abandoned Schuldeis plastic for mesh, because that is very driven by the industry. But I think it's pretty clear that here we use mesh. The first point, I think, is one of the slides which has to do with quality of surgery or experience, etc. I think I would emphasize here that in an academic center, we need to take that very seriously. We have a section of general surgery and parietology where these cases are going and concentrated, and I think that play a major role in the quality of surgery and recurrence after that, and even complication during surgery, recognition, etc. So, of course, this is another complex procedure which is often not taken as such and result in some issues. So, I think it was a very good move here that we developed the parietology and general surgery together as a section of surgery. My question is about the mesh now. You go to the mesh. We have mesh with omega-3, we have different mesh. They are expensive, and I think might be good to have some information about which mesh we should, or maybe better the one we should never use in terms of the mesh. Technically, now I don't do many of these procedures. I take you guys to do these procedures. We were putting the mesh with strong stitches, and now I see that you use exclusively glue, and the mesh is barely fixed. It's just placed correctly, and it is not fixed. Just that you may comment maybe on these two technical points.
The different meshes on the market is a huge problem, because to get a mesh on the market, you don't need a lot of studies. And we have the policy to use always the same mesh, and mesh that where we have long experience with it. And there are some meshes that are new on the market, and everybody tries them without really having the experience. So I would recommend to stick to a well-known mesh and to always use the same mesh. Regarding the fixation technique, and we have made the experience that these stitches are very painful in some patients, and we have to remove these stitches. And then sometimes we have a complete relief of pain. And so now we started using fibrin glue to fix the mesh and to glue in the mesh in the abdominal wall. But of course, if you do an intraperitoneal mesh placement, you can't use glue, because you will have more adhesions. There you need tacks or stitches.
I mean, just you are showing this interesting, more than 35. I'm not sure there are many who do more than 35 such cases, unless specialized center, maybe that's less, I mean, single digit number in the world. Probably the realities will be to know the lower part. What's the difference between doing 1 or 2 a year, which is probably what's going on for many general surgeon or us specialized surgeon, versus doing 5, versus doing 10, etc. And there is any data that indicate the outcome? Of course, you need multicentric study and maybe smaller hospital. Do we know?
It's very poor data. We only found this study, and there's very poor data on this topic because it's not so interesting for most surgeons. Finally, yeah.
Thank you. No role for primary repair anymore for even for small incisional hernias, or are we obligated now to put in every patient a mesh?
I think it's quite clear now that you should always use a mesh. Perhaps there's a role for suture in trocar hernia, very small hernia, that hasn't been closed, for instance.
Yeah, I have a question about how cost effective is it with the DRG system when we see how expensive it is to put in these mesh, the glue, the secure strap or whatever, and we have material costs of 3,000-4,000 francs a case. So how cost effective is it?
I think this is an important issue because for a private surgeon it might be important. It might be important not to use the most expensive mesh and so on, but finally it's the patient who is important. And from a socio-economic point of view, it makes sense to have a very good quality here because often these are young patients also that are still in the working process, and we should use the money here, I think.
Thank you very much. I have a question to the prophylactic use of meshes in incisional to prevent incisional hernias. Are there any limits for what patients we should use the prophylactic mesh? So what length of incision, what BMI, are the risk factors? Because I probably that correlates to some risk factors. Not every patient should get a prophylactic mesh.
It's a very good question. Most of these studies have been, these randomized studies have been only performed in selectioned and pre-selected patients. But this study from Brosi has been done in all patients, in all general surgery patients. And it's possible that in some years we will start putting in a mesh in every patient. You can even put in a mesh in a patient who has open colon. For example, colonic resection, but I wouldn't recommend to do it if you really have a peritonitis. And finally, at the moment, I would recommend to put in a prophylactic mesh in patients at high risk for incisional hernia. For example, if you close open abdomen or patients who have aortic aneurysm.
Okay, good. Thank you.